What we are going to discuss today is, first, let me give you some background about myself. My name is Patrick Bavaro. I'm a firefighter paramedic down here in South Florida. My department has been using the Handtevy system now for about 3 years, and I've been working here with the Handtevy company for about 2 of those years. So what we're going to go through today is we're going to go through about a 25 to 30-minute presentation on the psychology on pediatric emergencies and how EMS relates to them, what the Handtevy system is, and a demonstration of our mobile application at the very, very end here. So without further ado, let's go ahead and kick it off. So for those of you that have seen our system before, whether it's been online, word of mouth, at a conference, whatever the case might be, we do offer the organization of equipment that comes with our Pelican 1550 boxes or our soft-sided reinforced bags. At the end of the day, organization of equipment is very important and great. But there are 100 different ways to do it. So what I mean by that is that if you have a means of doing organizational equipment at your department that's working for you, and you do not find the need to switch to another type of organizational equipment, that's completely fine. The main benefit of our system is that we actually create a system that's customized 100% to a specific department's protocols and medical direction. So on the left side of your screen there, you will see the cover page for our Denver paramedic book that we made for Denver Health. This system is created unique to Denver Health. So we will go through some demonstrations and some presentations of what those customized medication guides look like. But we also have now incorporated our electronic version of those customized medication guides, otherwise known as our Handtevy Mobile. And what this mobile is it allows for electronic means of having available on your iPhones, Androids. It's compatible with iOS, Androids, Windows 7, 8, 9, and 10. And at the end here, we will go through, again, the demonstration of that. And this does have the means of actually integrating directly into your EPCRs and flowcharts once we get integrated with the software that you are utilizing. So what our goal here at Handtevy is to really change the way that we look at pediatrics. Over the last 30 years or so, emergency medicine in general has really taken leaps and bounds and progressing. But when we really get down into it and take a look at pediatrics, we really haven't changed the way that we really approach those types of patients. And what I mean by that is that when we get called out to the scene, we really just haven't progressed. And the reason being is that when we get called out to the scene, en route to the scene, we really can't do anything prior to arriving. You get on scene, you pull out the tape in front of mom and dad, and then from there, the paramedic is expected to convert, milligrams to milliliters. And really, there's two choices to make. Either the paramedic is going to stay on scene and treat that patient, or option 2 being that the paramedic is going to throw the kid in the back of the truck and burn diesel fuel to the hospital. And more frequent than not, option 2 is the option that is taken. And myself, and I'm sure the majority of you as well, have been through ACLS and PALS. So why is it that when we look at a adult cardiac arrest, for instance, the national average on-scene time is anywhere between 20 to 25 minutes. But when we look at a pediatric cardiac arrest, the average on-scene time is only 5 to 7 minutes. To me, the 2 courses are for the most part identical, small changes in algorithms of bradycardia, things like that. However, when you look at a cardiac arrest, it's for the most part exactly the same. So why is that? Why are we staying on scene with these pediatric patients? And it simply comes down to the confidence within the providers. They don't feel confident enough treating that patient. It's their once in a while type of call, low frequency, high acuity, don't do that much training on it, etc. So what we do is that we build the confidence within our providers to actually stay on scene now and treat that patient just like they would with any other patient. And the way that we do that is through our customization. So all of our customization is being managed through our online portal, or as we call it, our medication management software. So through that portal, what ends up happening is that you will be assigned a member of our med team who's comprised of pediatric ER docs, pharmacists, and clinical coordinators. And what will end up happening is that you'll actually work with that person in creating a system that's, again, unique 100% to what you guys are actually utilizing and doing at your service. So that includes all your medications, concentrations, backup drugs, shortage drugs, your equipment, your electrical, etc. And through that, we also offer department-specific training. So with any level of implementation of our system, whether it's the bags, the boxes, the books, the tapes only, the mobile only, etc., you will get access to our online education and training portal. So through that portal, you're going to find how to successfully implement the system through a narrated, notated video, as well as supplemental info on pediatric resus, psychology on pediatric emergencies, pediatric pain med administration. So you'll have tests, pre-tests, post-test quizzes, PowerPoints on all those different types of topics. And more recently, what we just came out with is going to be our Handtevy course. So back in November, we launched our Handtevy course, and what that is basically going to serve as a replacement or an alternative to the PALS program. So it is CAPC approved, which means that it is recognized by the National Registry and at the state level. And essentially, there's going to be two versions of that course. You're going to have the Handtevy instructor course, which is going to be an 8-hour course. So whether you come out to us, we come out to you, you go through an 8-hour course, you become a certified Handtevy instructor, you get awarded 8 hours worth of CEUs for $295. It's good for a period of 2 years. And then from there, what you're able to do is go back to your department and area and teach the Handtevy provider course. So the Handtevy provider course is going to be a 4-hour course that awards 4 hours worth of CEUs, and it's only going to be $15 per provider to get awarded those 4 hours. So it's something that we're very, very excited about. It's an EMS specific course. It's not a hospital course that was adopted by EMS because there, again, really wasn't anything else out there. The nice thing about the course is that it's relative to your department and what you're actually utilizing and using in the field. So it's not the medication, it's all the medications, it's all the concentrations that you guys have. It comes, it's molded to fit what you're actively doing. So again, we're very excited about that. And if you would like some more information on that, I'd be more than happy to provide that for you. So all this here leads to a culture change, which will inevitably lead to better patient outcomes. So to give you an idea about where we're at here in the country, over the last 4.5 years, we've been actively on the market. And within those last 4.5 years, we've been implemented in over 240 EMS agencies and hospital systems across the country. So those include regional services, county-wide services, the individual municipalities themselves, volunteer departments, and many others. And some of the more notable ones to adopt our system last year are going to be New Orleans EMS, DC Fire and Rescue, St. Louis, Memphis, Anchorage, PHI, Air Methods actually just sent in their PO for purchase of the Handtevy system across their entire fleet last month. So we're very, very excited about that. And more recently, AMR has now been approved nationally to procure the Handtevy system at their individual services within AMR. So very, very excited about that. And we look forward to working with you all. So kind of backtrack a little bit and discuss how we kind of came about. Dr. Peter Handtevy is our founder and CMO. He's an ER doc down here at Joe DiMaggio's Children's Hospital, and he fills a unique role in that he's a pediatric doc, but also fills the role of being a ALS medical director for numerous departments down here in South Florida. So once he started filling that role of medical director, he quickly realized that his paramedics were not as confident as they should be when going on a pediatric call. And obviously, being a pediatric doc, he wanted to change that. So after reading a book called Thinking Fast and Slow by Dr. Daniel Kahneman, Dr. Kahneman explained that there are two parts of our brain in the way that we think. So there's going to be the system 1 or fast part of how we think, and the system 2 or slow part in how we think. So system 1 is very arrogant, it's cocky, it's your more everyday type of operations. And an example of that, if I said not to answer this question and I asked you, what is 2 plus 2? It's probably already too late. The majority of you have probably already thought about the answer being 4, even though I said don't answer it. And that's just how system 1 works. So that's where the adult treatment spectrum falls into. It's your everyday type of call. It's it's all pre-dosed, pre-sized. You know what you're going into for the most part. Whereas system 2 is going to be very slow, very effortful. I like to think of it as a gas tank, that after so much use of it, you simply tap out and don't want to be there anymore. And that's really where the pediatric realm of treatment falls into. So to relate this into EMS, if I ask you what are the 3 doses for these 3 types of medication for a 6-year-old patient, you're going to tell me that's very simple. It's going to be a full amp, and then depending on protocols, either 25 or 50 of Benadryl. So again, system 1. Now, if I ask you for the same exact 3 medications and for the same exact 3 scenarios for a 5-year-old patient, you're going to have to ask me, okay, what color does the kid fall into? How much do they weigh? Now I have to look at my protocols. Do I carry a D10 or D25? Is it pre-mixed? If not, how much D50 do I need to push out? How much saline do I need to withdraw? And then how much actual volume do I need to administer? Same thing with Epi, same thing with Benadryl. And then we start getting into some of our more complex medications that will be packaged this way one part of the year, the other way the other part of the year. So again, just numerous variables involved. And what we've done now is taken that system 2 thought process out of pediatrics and made it into a system 1 thought process. And we'll explain how that is towards the middle part of our presentation here. So to discuss some of the issues that EMS face across the country, all medications require math. You can only start treatment after arrival and measurement of that patient with any length-based system out there. The Brazo tape is not customized. It's a standard tape that's used across the country. And we'll actually go into some of the discordance rates here in just a moment. Poor documentation accuracy, and documentation is not in real time. So those last 2 bullet points will actually be addressed here at the end of our presentation and cover both pediatrics and adults, and we'll again discuss that during the mobile demonstration, so please remember them. So this presentation isn't really to harp on the Brazos system. When it first came out 30 years ago, it was revolutionary, it was ingenious, but at the end of the day, we're not going on those pediatric cardiac arrests that frequently. However, we are going to go on our bread and butter calls, as we call it, a little bit more often. And those calls include calls like anaphylaxis, femur fractures, or pain management, and seizures. So I know that when I went through paramedic school, I was taught that when you hear or think of pediatric, you think of Brazos being your tool to utilize. However, we quickly realized once we get into the field that this is not 100% accurate. And unfortunately, since we don't do that much training on pediatrics and don't utilize the Brazos tape and other systems out there that often, we're not too aware of what's actually on that tape. So you'll notice that all these 3 types of medications that are required for these types of scenarios or patients are going to be found on the Brazos. However, they're going to be found for different purposes. So what I mean by that is that, and unfortunately, we've seen this in trainings and unfortunately in real life scenarios as well. So I do challenge you to go back to some of your paramedics and test them on this to see if they fall into this trap. But whether you're treating a severe anaphylaxis case, and let's say the paramedic needed to give epi 1-to-1, they pull out the Brazos tape, they don't recognize that the epi 1-to-1 dose on the Brazos tape is going to be the ET tube dose for resuscitation. They end up giving a 10-fold overdose. Same thing with fentanyl or morphine. There is no morphine dose listed at all on the Brazos, and I know that morphine's been getting phased out for the most part, but the fentanyl dose listed on the Brazos is going to be for RSI. So again, there is no pain management dose on there. That'll be a 3 to 6 time overdose depending on concentration. And then same thing with seizures. There is no midazolam dose on the Brazos system. There is one there for RSI though, and depending on concentration, again, 3 to 6 time overdose. So this just kind of highlights how easy and quick it is to make those mistakes. I know down here in South Florida in Broward County anyways, the majority of the departments, I think there's only one actually that still does RSI or is allowed to do RSI rather. And the reason that we don't do RSI for the most part is that we have short transport times. And on top of that, the number of errors that we were experiencing when we did have RSI approved was just enormous. So these medications listed here on this tape mean absolutely nothing to me now. And at the end of the day, they just add to the confusion and error-prone medication dosing that we have with pediatrics inherently. So discuss some of those discordance rates. Myself and Dr. Handtevy were actually at the NAEMSP conference in San Diego back in 2016. We were actually just there and met your group there on in New Orleans a few weeks ago. So it was very nice to meet all of them. However, back in 2016, we did a poster abstract comparing 38 EMS agencies' protocols to the Brazos system. And what we found was that 10% of EMS meds found on the Brazos are at the incorrect dose, and that 39% of EMS meds were not even listed at all on the Brazos, which led to a 49% average discordance. So that's a very, very high number, especially when we're looked at in the public eye as being Superman, Superwoman, and there to save the day and save that loved one. When we're utilizing a tool that doesn't allow for us to properly reference it in terms of dosing and getting medications on board and interventions done, all that, that's what ends up leading to paramedics going back to the station and thinking, could I have done something different to save that kid, or could I have done if I had done this instead, would that have saved them or brought them back? And no paramedic wants to go back to the station feeling that way, because that's what ends up leading to those ghosts that haunt these types of or these people for so long, that unfortunately that ends up leading to suicide and other things like that. So we want to alleviate that stress that comes along with those types of calls. So these are some of those medications listed there for you. This is the actual poster abstract. It is going to be found on our website. I am more than happy to send it to you as well. Just please ask me for a copy if you would like, and I'll be more than happy to send it. But it's going to be found on our website. The state of Maryland actually runs a statewide protocol. So it just so happened that I was in Howard County, which is right next to Baltimore County, and Prince George's County, and a little bit north of DC, back in July. And it just so happened that July 1st, they came out with their new statewide protocols. So What we ended up doing was doing a comparison of the state of Maryland's protocols to the Brazos system. And what we found was that they had a 55% discordance. So Howard County now does now use our system. It's been very successful for them, and we're seeing Prince George and all the other surrounding counties started to take an interest in evaluating it now that Howard County has really piloted the system there. So very excited about that. A group of very well-known docs out of the Phoenix and Denver area did a study comparing the 7 evidence-based guidelines that are put out by organizations like AHA, NAEMSP, groups like that, and compare the 26 medication recommendations that they make, and found that only 15% of the medications listed on the Brazos were correct, 54% were not listed at all, and that 31% were listed incorrectly. So again, this isn't just coming from us now, this is coming from a much more broader scale. And people are starting to realize that, again, the Brazos does serve a purpose, and you are able to treat some pediatric patients with it, but it does leave a lot of room for error, and it's not a full solution to an inherent problem that we have when it comes to pediatric dosing. So there are numerous studies out there that show that about half the time that a paramedic is giving a pediatric any sort of medication, they're either overdosing or underdosing that pediatric. And again, that's about half the time. So very staggering numbers. Denver Health, a large hospital system out of the Denver area, obviously, wanted to do a peer review prior to implementing the Handtevy system. So what they did was that they took 80 of their paramedics and gave them 2 very common scenarios using dextrose and epi. They had been using the Brazos system now for many, many years. It's what they've been trained on. That's all they knew. They got a quick 2-minute overview of what the Handtevy system is, how to utilize it, and you can see that their error rate was significantly higher while using the Brazos system compared to the Handtevy system. And at the very end of that peer review, they asked their paramedics what they thought of the 2 systems. 98% of them found it to be easier, 91% of them found it to be faster, and 88% of them found it to be more accurate. So Denver Health now utilizes our system. They've been using it for about the last year or so. So this peer review definitely helped them out a lot and helped us out a lot as well. So now that we've gone through all the psychology and back ends of what our system actually is, and now we're getting into the back ends of pediatrics. Now we're getting to what our system actually is. So really there's going to be 2 main differences between our system compared to really anyone else out there. And the first one is going to be that we're going to be an age-based hybrid system. So what that means is that with our system, you're going to learn that a 3-year-old, for instance, weighs ideally 15 kilos. So what that allows you to do is that prior to, let's say you call that dispatch to a 3-year-old drowning, anaphylaxis, femur fracture, whatever the case might be, prior to arriving on scene, you're able to start determining what size equipment you might need, what medications you might need to administer, how much medication based on the nature of the call, and you start that pre-planning process just like you do with your adult patients. That way there's more confidence, less anxiety. You get off the truck and your paramedics know what they need to be doing, and they're not fumbling around looking for a tape or measuring the kid and converting milligrams to milliliters and having that scramble mentality. Now we do have a backup color-coded length-based tape that's going to be used when the kid is too tall, too short for their age. You don't know the kid's age. You'll pull off the tape, measure the kid. They fall into a color category. And then from there, you would refer back to your customized medication guides or mobile for treatment. There are no actual concentrations, medications, or equipment on our actual tape itself. It's just simply used as a backup means of determining the child's weight. So one of the questions we get asked is age an appropriate means of identifying the ideal body weight of a child? The simple answer to that is going to be yes. So Tim Young out of the Loma Linda area did a study comparing a finger counting method or an age-based approach to a length-based approach. And what he found was that they were actually statistically equivalent. So the AHA does recognize a finger counting or a finger counting or age-based approach to determining the ideal weight of a child. They do recommend having a length-based tape in any pediatric system for, again, when the kid is too tall, too short for their age. And we do check that box as well and make that same recommendation. What we did here was that we actually took Tim Young's study and recreated it using real patient data. And you can see from the 2 plot diagrams that they're for the most part identical. At the end of the day, if you're off by 1 or 2 kilos when estimating that child's weight, it's not going to be a detrimental effect to that patient. You're trying to work within that therapeutic range of treatment and avoid that 3, 6, 10-fold overdose that we're seeing, again, all the time with medication administration for pediatrics. So, one of the questions we typically get asked as well is in today's day and age, especially here in America, kids seem to either be overweight or sometimes even obese. So how do we treat those kids? The simple answer to that is going to be that 95% of the medications that we administer are going to work off the ideal body weight of that child and their water content. So, we're made up of 70% water. So those medications that we're administering aren't going to take into account the actual fat content within that kid. However, there are going to be some medications that do take into account that fat content, and those are going to be like Sux and amiodarone. So let's say you're treating a 5-year-old patient who's supposed to weigh 20 kilos, and he still measures out as a 5-year-old range or a blue, but in reality, he actually weighs 30 kilos. And let's say you're onboarding Sux, for instance, and you notice that, hey, this kid's not fully paralyzed yet. Again, there might be a little bit of paramedic judgment involved there, saying that, hey, I need to up my dose a little bit. And that's just simply knowing pharmacology and what meds, take into account that fat content. However, again, what we're trying to avoid is going to be that 3, 6, 10-fold overdose of medication dosing that we're commonly seeing. So, and just to kind of reiterate, just to make one other point, if we take a look at something like the EpiPen Junior, for instance, that is going to cover a wide range of age groups and weights. So again, you're just trying to work within that therapeutic window and get actual interventions on board, as opposed to having the mentality of getting to the hospital as quickly as possible. So the second part of how our system is different is that, again, we are fully customized 100% to a specific department's protocols and medical direction. So these are actually pages out of the customized medication guide that we did for North Memorial Ambulance Service in Minnesota. They are a large hospital-based EMS service. If we take a look at the 6-month-old patient here, or 6-month-old page here, you're going to see that they have every single medication, concentration, backup drug, shortage drug that they want to have on here listed for them alphabetically A to Z. They've color-coded some of their medications to be different colors. So I've seen some departments put their cardiac drugs in red, RSI in blue, NARCs in blue. It's completely up to what you want to actually do at your department. You will also have mixing instruct. You can also put mixing instructions next to certain medications. You can put side notes next to them saying it's the first dose, second dose, etc. Again, completely up to how you guys want to customize that. But more importantly, in the highlighted light blue section, you're going to have all the volume forms of medication. So again, it's alleviating all that, converting milligrams to milliliters. There's more confidence in the air now, and the paramedic is actually staying on scene and treating that patient. Now, our system is going to cover a Premie 2-kilo patient all the way up to a 13-year-old 60-kilo patient. And it's also going to cover a 75-kilo and a 100-kilo adult patient customized the exact same way. So it does cover both pediatrics and adults, making it more of an everyday type of use as opposed to a once-in-a-while type of use. The very bottom of those pages, you're going to have your electrical settings. So you'll have, if you guys use LifePak, Zolls, another type of monitor, you have your first, second, third, and fourth round of cardioversion and defibrillation listed there for you. Same thing with your airway. So Seminole County here in Florida, they just wanted to put ETs and king tubes on there. New Orleans EMS, they put ETs, king tubes, iGels, and LMAs. Again, up to whatever you guys want to include. And at the very, very bottom, you will have the vital signs of what the parameters of a healthy patient in that weight range or age group should be within. So at the top, you'll notice that you'll have the color, the weight, and the age all associated with this patient here. The very back of the book, hopefully you never have to use it, but you will have your Hazmat toxicology pages. So you have all your poisons, all your antidotes, how to mix them, how to apply them. Same thing with cyano kit instructions for you there as well. And then from there, you can get a little bit more customized. So some departments put in pediatric glaucoma and burn charts. I've seen St. Louis Fire Rescue, they put in EKG, salt mass casualty, and a pain scale. Some of our critical care services will put in ventilator settings, hospitals they transport to, criteria levels. Again, it's completely up to what you want to include on there and what would benefit your paramedics the most. So the last 2 or 3 slides here before we go into our mobile presentation is going to be on our pre-deployment versus post-deployment data. So Polk County Fire Rescue serves a population of about 600,000. Their medical director, Dr. Paul Banerjee, actually went ahead and submitted this information to us and is in the process right now of actually publishing a paper on it. So we're hoping to see that paper in the next few months here. We're very, very excited about it. And before we discuss this data here, I want to say that this is all of their pediatric cardiac arrest data for these 4 years. So these are kids that were EMS related, trauma related, those that got bystander CPR, those that didn't, those that had stay and play mentality applied, those that had load and go applied. So this is, again, all their pediatric cardiac arrest data. So 2012, 2013, they were utilizing the Brazos system. You can see that they had 38 pediatric cardiac arrests between those 2 years. Their ROS return percentage in 2012 was 0%. In 2013, it was 11%, so pretty low. And then if you take a look at the survival to discharge, 100% neurologically intact from the hospital based on these ROS return percentages, it's going to be 0% for both years. So there were kids that did make it out of the hospital. However, there was some form of neurological deficit. And obviously, as providers, we want to see a fully successful outcome. So in 2014, they implemented the Handtevy system. You can see their pediatric arrest data went up a little bit higher for those 2 years. However, their ROS return percentages went up to 33% and 29%, and their survival to discharge 100% neurologically intact from the hospital went up to 71% and 78%. So a total of 12 kids made it out of the hospital, or based on these ROS return percentages. So a total of 12 kids made it out of the hospital 100% neurologically intact. And, we asked Dr. Banerjee, why are these numbers so completely different from what you guys were doing before? And he said that since implementing our system, their paramedics now are staying on scene for about 15 to 17 minutes on average with any pediatric cardiac arrest, whereas before they were only on scene for 5 to 6 minutes. So this is the only difference in change that they've made in terms of pediatric treatment. And we're actually still collecting the final data for 2016, but we're told that it looks just like the previous 2 years. So very, very excited about that. We hope it happens everywhere, and we're starting to see that change occurring in different places. So continue on. So Denver Health, again, a very large hospital-based EMS service. They see about 100,000 calls a year. After implementing our system, they saw a 116% increase in fentanyl IN administration and almost a 200% increase in Versed IN administration. And at the end of the day, the reason being is because now their paramedics, again, are staying on scene. They know exactly how much medication to be giving. They're not worried about their math being wrong. They're doing something more detrimental to that kid, their job being on the line, getting sued, and they're actually administering medications like they're supposed to, which obviously leads to improved patient care. So real quick, we're going to go into our mobile demonstration. So right now I'm on the web-based browser version of our system. So again, this is compatible with iOS, Android, Windows 7, 8, 9, and 10. And the only one that's going to require a web-based browser version or a constant connection to Wi-Fi or cellular is going to be found on our Windows 7 platform. The reason that Windows 7 requires this constant connection is that it's going to be an older software. It didn't allow for third-party connections like that. However, all the other platforms are going to work as an app. And what that means is that once you make that initial connection and download of it, everything that we're about to do here can be done through the app, through it itself. It lives internally within the app itself. The only other time you'll need a Wi-Fi or cellular connection will be to either make updates to the mobile or to actually submit your reports. So right now we're in a New Orleans account. So this is specific to them. So now we'll go to start new patient. You'll see here you have all your age groups, Premie, all the way down to your adults down here at the bottom. So let's say that we select our 2-year-old, That customized page for that 2-year-old now comes live right there on your screen. Let's say that we select Benadryl. We want to give 0.2 mLs. We select it. We can have our different routes of administration, IV, IO, IM. Let's say that we give it IV though. We hit given. It's going to timestamp it turning green. Let's say we want to give some Epi 1-to-1 now. Click Epi 1-to-1, 0.1 mLs. Hit given. Timestamps it turns in green. We go down to our left side of our screen here and go to our airway because we're ready to do some airway. Try doing an ET tube, 3.5 cuffed. We'll say that it was unsuccessful. We'll do an iGel size 2 now. Say that was successful. And we'll say that our patient crashed and we're ready to do some defibrillation. So we click defibrillation, go to our first round at 20 joules. We hit successful. And now we've saved our kit and we're ready to submit our actual report. So what ends up happening is that you'll go to review and submit chart. You'll type in your name saying that Patrick was the one who charted it. You'll type in your record number saying it's 123. We'll type it in again, 123. You can put any additional notes in here about the call if you'd like to. It's completely up to you. But from there, if you want to make any sort of changes or modifications to anything that was administered, let's say we select Benadryl. You can change the route, dose, time, concentration, put any side effects about that drug in there if you'd like to. And then from there, we simply back out of it or hit update if you make any sort of change. You'll select, if everything looks good, you select this checkmark box. You'll hit submit. And what ends up happening from there is that through submitting it, once we're integrated with your software, this report will go up to the cloud. That cloud will be connected to your Toughbook software. And from there on your Toughbook or on your software, you'll get a notification saying that there is a new report to import. And from there, you'll go into that report, into that section, you'll find that report, you hit import, and from there, it'll build directly into the actual flowchart and patient care record that you're working on. So we're very, very excited about that. One of the other functions that you will have the option of utilizing, whether you're integrated or not, will be our fax and email capability. So simply, all you would do is go to Chart Archive. You'll type in, you'll go to the report that you want to send off. So we'll go to the one that we just did, which is the second one right here. We'll select it. And from here, you're going to have a predetermined list of email and fax locations that are put in by your administration. So These are all predetermined by your administration. I've seen some departments put in hospitals they transport to, EMS chiefs, medical directors, administration. Again, it's up to what you want to have on there. And all you do is you select who you want to send it to. You hit send. I'm not actually going to send it though, so I'll back out. And the other nice feature about the mobile is that the mobile allows for near to real-time updates. So what I mean by that is that when you have a concentration change or shortage of medication or a protocol update, all you would do is you would log into your medication management software. We would take out the old one, put the new one in, and now you have an up-to-date system of what you're actually utilizing in the field. So you can do that as many times as you want throughout the year. There's no number to how many times you can do that. So it's a very exciting feature that we have. And just real quick, I want to show you what those email and fax reports look like. So as they come through, you'll have your department logo on there, who was charted by, the record number, the date, where it came from, what rescue unit or what unit it came from, first intervention, last intervention, all the actual interventions here, when it was completed, and then just summary of key points, last slide. With Handtevy versus Brazo, with Handtevy, no math is required. You initiate care prior to arrival. It's customized 100% to your agency. Documentation is now streamlined and continuing education. So with that,